This conference will now be recorded.
Okay. So today, from today onwards, what I have decided, first we will complete 2020 talks first, and then we will go back to the 2018 and 2019 ones, so that you will be very well versed with this 2020 talks. So I have started backwards. So I have started today from October 2020 talks. Okay. So this is the first talk. This is in the recent talk, that is differences in sexual development and their clinical implications. So I think this is the best talk actually, because till now we never had any proper source to study regarding what are the investigations should be done for this congenital adrenal hyperplasia, what are this all disorders of sex development. So there were never a proper source was there. We used to gather information from so many sources like TOG, old talks and this thing. And again, we used to confuse these investigations to do what to do. So now I think they have given a comprehensive information of all these disorders here in this talk. Okay, this is a very good talk actually, I should say. So we will start today this. So nomenclature. So what do you mean by disorders of sex development? So previously these are called as intersex disorders. Then they have changed it to disorders of sex development, because intersex disorders or ambiguous genitalia or hermaphrodites. So what they thought is, this is basically because it is a gender identity issue, so it is very sensitive issue, so it should not be given some extreme names. So they have come up with this name of differences or disorders of sex development. And now for ambiguous genitalia also, it is called as atypical genitalia, not ambiguous genitalia. So you should be aware of these two nomenclatures. That is, one is differences or disorders of sex development and atypical genitalia. These are the two terminologies which is used nowadays. So before we go into details of disorders of this sex development, we should know exactly how this normal sex development occurs in fetal life. So prior to 6 weeks of gestation, both the male and female, both embryos, these are indistinguishable. So before 6 weeks, we can't tell sex. But after 6 weeks, so before 6 weeks, they will have both Mullerian and Wolffian ducts. Okay, and the gonads will be bipotential. Now, what happens after 6 weeks in presence of Y chromosome? The gonads will begin to develop into testes. Okay, and how it is going to start the development is, it depends upon the sex determining region on the Y gene. Okay, it is known as SRY, sex determining region on the Y gene, which triggers a series of reactions or gene expressions, so which will result in the secretion of AMH from Sertoli cells. So this SRY is responsible for AMH secretions from, sorry, 1 minute. Okay. So this SRY is responsible for the AMH secretion from Sertoli cells, and which will causes this involution of Mullerian duct and Wolffian duct persists. So in males or in male fetuses, this Wolffian duct persists and Mullerian duct regresses in presence of this SRY, and because of this AMH. Okay, so you can see in this flow chart here very nicely that, see, this is this, in case of male fetus, this SRY will be there. Because of this SRY, the testes, Sertoli cells will secrete AMH, which will cause degradation of the Mullerian duct. While also because of this testis, testosterone will be secreted, which will cause us maintenance of this Wolffian duct. So internal genitalia will develop into the testis. Okay. So Wolffian duct causes testis and other internal genitalia development. While this peripheral, the testis will, in the testosterone, which will be converted by 5-alpha reductase to DHT. So this 5-alpha reductase will cause conversion of testosterone to DHT, and this DHT is responsible for external genitalia. Okay, so For external genitalia to develop, it requires DHT, while internal genitalia will develop in presence of testosterone. Okay, so this is regarding the male development. Now, in case of female development, female genital development, what happens? Because there is no SRY, there is no SRY region, or there will be no Y chromosome, so there will be no AMH and no testosterone. So because of this, Mullerian duct will remain, and because there is no testosterone, Wolffian duct regresses, and there will be no DHT also. So there will be no male development of external genitalia, and because of this Mullerian duct develops into the female internal genitalia, that is uterus and fallopian tubes and other things. So this is the development of internal and external genitalia. So now what happens in external genitalia? So rudimentary external genitalia, these are genital tubercle, urogenital folds and genital swellings. Okay. So what happens in case of male, as I told you, because of conversion of testosterone to DHT with 5-alpha reductase, it will causes development of this external genitalia of male. So how it differentiate between these two things is, so genital tubercle becomes glans in case of male, while it becomes clitoris in case of female. Urogenital fold becomes penile shaft in case of male, and it becomes labia minora in case of female. Genital swelling becomes scrotum in case of male, and labia majora in case of female. So this is the external genitalia development in presence of DHT, that is dihydrotestosterone. So now this is regarding the normal sex development. Now what are these disorders of sex development? So anomalies in genitalia, it is incidences around 2%, while truly atypical or ambiguous genitalia, what we call it is, so it is the incidence of this truly atypical genitalia is 1 in 4,500 to 5,000 live births. So now this truly atypical genitalia or disorders of sex development. So basically these are divided into these three things. One is gonadal dysgenesis. So gonadal dysgenesis means what? Complete or partial failure of development of gonad. So differentiate either into male or female. So it is called as gonadal dysgenesis. It is pure gonadal dysgenesis. Then ovotesticular differences. That means it is the presence of both. Ovotesticular means it is presence of both female and male gonadal tissue, okay, in the same individual. So it is ovotesticular differences. And testicular DSD is testicular presence of testicular tissue in female karyotype. So testicular tissue presence in female karyotype is testicular DSD. So am I clear? So there are three types of this DSD. One is gonadal dysgenesis, which is either complete or partial failure of development of gonads only. Okay. Ovotesticular means presence of both in same individual, male and female. And testicular is only presence of testicular tissue in female karyotype. So these are again, so it will be again divided into, one is chromosomal disorders. So chromosomal disorders, in this what happens? First is, as you know, most common is Turner syndrome and Klinefelter syndrome. So Turner syndrome is 45X0, Klinefelter is 47XSY. Okay, and this Turner and Klinefelter, again it is mosaic karyotype can occur in case of this both Turner and Klinefelter, and chimera karyotypes. Chimera karyotype means presence of both single in 46XX and 46XY. So it will cause ovotesticular DSD. Then translocation of SRY into X chromosome. Okay. So this translocation of SRY region on the X chromosome, so it will cause this development of testicular tissue in female karyotype. And this defunctioning mutation of SRY. So it will cause in 46XY. So in male karyotype, it will cause gonadal dysgenesis, which is called as Swyer syndrome. Okay. So Swyer syndrome, it is the mutation of SRY gene that you should know actually what is the difference between androgen insensitivity syndrome. What is the difference between Swyer syndrome? So Swyer's and androgen insensitivity, the basic thing is only functional difference. So Swyer syndrome is mutations of SRY, while androgen insensitivity is the receptor defect. Now 46XY disorders. So see, I have they have divided in this TOG, they have divided into this three types. So one is chromosomal disorders. In that case, there will be either aneuploidy, triploidy, or any mosaic karyotypes. Okay. Then second thing, it is 46XY disorders, and then 46XX disorders. So karyotype is determined, karyotype is normal, still gonadal dysgenesis is there. So in case of 46XY disorder, there will be gonadal dysgenesis, as I told you, Swyer syndrome, ovotesticular DSD, again disorders in androgen synthesis like 5-alpha reductase deficiency, complete androgen or partial androgen insensitivity syndrome, 17 beta hydroxysteroid dehydrogenase deficiency, LH receptor defects, and other causes of cloacal extrophy. 46XX disorders, these are again gonadal dysgenesis or testicular or ovotesticular DST, androgen excess in case of congenital adrenal hyperplasia, exogenous androgen, presence of exogenous androgen, and others are Mullerian anomalies and cloacal extrophy. So we will look into each one. Now they have given in short description of each of this. So Turner syndrome, I don't think you require more detailed description of Turner syndrome, but yes, it is a karyotype is 45X0 or it can be mosaic karyotype. It is the most common female sex aneuploidy. Remember when? So Turner syndrome is the most common female sex aneuploidy. Okay, sex chromosome aneuploidy basically it is. While other aneuploidies most common are, it is the Down syndrome. Okay, so regarding autosomal aneuploidy, it will be Down syndrome, while sex chromosome aneuploidy, it will be Turner syndrome. So it can be also caused by mosaicism, which can, some cells will carry 46XX and some cells will carry 45X0. The clinical manifestation, short stature, ovarian hyperfunction, premature ovarian failure. Some patients may enter into puberty. Few will progress to menarche and full development of sexual characteristics without aid of exogenous hormones. So only few patients will reach the menarche. They will have menstruation, but ultimately they are going to have this premature ovarian failure. And most of the people, they will require exogenous hormone for the initiation of their puberty. Then complete and partial androgen insensitivity syndrome. So it is the resistance of the androgen receptor to the binding of testosterone and DHT. It results in androgen insensitivity syndrome. So it can be divided into complete or partial. So in complete or partial, whatever, the karyotype will be XY and gonads will be testes. Okay. So internal genitalia, they will be testes. Karyotype will be XY. Uterus will be, or any Mullerian duct organs will be absent. So Mullerian duct, it regresses because of there will be AMS secretion, because testis will be there and AMS secretion will be there. In the presence of minimal testosterone action, Wolffian ducts are maintained in half of the cases. Now, at birth, external genitalia will have female appearance because there will be no DHT. Okay, because these receptors could not bind to testosterone, so there will be no DHT. So there will be no conversion of testosterone to DHT, and because of that, there will be no external genitalia differentiation. So it will be external genitalia will be female. Breast will develop normally at puberty because there will be peripheral conversion of testosterone to estrogen. So there will be breast will be normal, gonads will be testes, karyotype will be XY, primary amenorrhea will be there, and scant pubic and axillary hair. So these are the diagnostic features of complete androgen insensitivity syndrome. And childhood, they may have undescended testes and bilateral inguinal hernias. So usually they will assign female gender because external genitalia will be of female type, and they will usually have gender identity as female only. Complete androgen insensitivity syndrome. I'm talking about complete. Okay. Now what happens in partial? Yes, the karyotype will be same. That is XY. Gonads will be testes. AMH will be there, but there will be varying development of Wolffian structure because the degree of sensitivity of these receptors will differ. So that varying development of Wolffian structures occurs, and external genitalia appearance will be also variable. So hypospadias is more common, and these patients, they are raised as male. Okay. So see, complete androgen insensitivity syndrome, their phenotype is female, while partial androgen insensitivity syndrome, usually their phenotype will be male. Am I clear? Now another thing is luteinizing hormone, LH hormone receptor defect. So LH receptor defect, what happened here is the testicular Leydig cells of this male individual, they are insensitive to stimulation insensitive to LH to produce testosterone. So the findings will be similar to that of androgen insensitivity syndrome because there will be no testosterone. Okay, but the defect here is deficiency of testosterone, not insensitivity. So see, androgen insensitivity syndrome, there will be testosterone, but it will not be functionally active, while here there will be no testosterone only. So here breast development will not occur because there will be no testosterone, so there will be no conversion will not occur of that testosterone to estrogen also peripheral, and there will be no breast development. So differentiation between this congenital and complete androgen insensitivity syndrome and LH receptor defect is there will be no breast development here, while in CAIS there will be breast development. Now another thing is, so we are talking right now about this 46XY this karyotype. Okay, so sex disorders with 46XY karyotype. Then the last thing here is 17 beta hydroxysteroid dehydrogenase 3 deficiency. So here this 17 beta hydroxysteroid dehydrogenase, it is responsible for the conversion of weaker androgen, androstenedione to testosterone. So 17 beta hydroxysteroid dehydrogenase is responsible for conversion of androstenedione to testosterone. So defect in this gene results in inability to convert androstenedione to testosterone. So here what happens? Testosterone will be there, but it will not be adequate to development of a male specific internal genitalia. Okay. So here what happens? Testosterone will be there, but it will not be adequate. Genotype will be XY. Karyotype will be XY. Gonads will be testes. Okay. Mullerian structures will not be there, but because of insufficient testosterone, there will be external genitalia. These are usually of female type or atypical type, okay, or ambiguous. So, but what happens here? The Wolffian structure develop even in even if there is insufficient testosterone, the other structure, other internal genitalia will develop into epididymis, vas deferens, and seminal vesicles. Why? Because there is presence of isoenzyme of this 17 beta hydroxysteroid dehydrogenase, so which are resistant to peripheral tissues, and so this gene defect which will not act on these isoenzymes. So other internal genitalia will be of male type, but external genitalia will be atypical or female type because there is inadequate testosterone. What happens? So it is at birth. Now at puberty, what happens? Increase LH, it will result in higher levels of androstenedione. So subsequently, this isoenzyme, they will again convert into more testosterone. So at puberty, there will be development of male sexual characteristics like growth of external genitalia, virilization, increased muscle mass, body hair. So secondary sexual characteristics of male will be developed at the puberty. At birth, the genitalia will be either ambiguous or female, but at puberty there will be normal development of secondary sexual characteristics of male type in case of the 17 beta hydroxysteroid dehydrogenase deficiency. Now, at birth, they are usually misdiagnosed as complete androgen insensitivity syndrome, but this enzyme deficiency, it is autosomal recessive, while this androgen insensitivity syndrome is autosomal dominant, and this enzyme disorders is very rare, but there is increase incidence in Gaza because of consanguineous marriage. So what happens at birth? Their gender is assigned as previously usually female, but at present there will be primary amenorrhea will be there and virilization will be there. Sometimes there will be breast development because of this excess androstenedione. It will be converted to estrogen in the peripheral tissue. So sometimes breast development may occur. So this is the atypical features of the 17 beta hydroxysteroid dehydrogenase deficiency. Now another one is 5 alpha reductase deficiency. This is 5 alpha reductase is necessary for conversion of testosterone to dehydrotestosterone. So this prevention of this, so DHT will not get formed, but still the karyotype will be XY, gonads will be testes, Mullerian structures will not be there, Wolffian structures, male internal genitalia will be there, but because of this absence of DHT, external genitalia are female. Okay, so all other internal genitalia, karyotyping and everything is male, but external genitalia will be female. It is the same thing that happens with 17 beta hydroxysteroid deficiency. So because of isoenzymes at puberty, there will be virilization. Okay. So, and one thing is there here, the difference of the 17 beta hydroxysteroid dehydrogenase deficiency and this thing is because there will be antenatal and postnatal exposure of brain to testosterone. So here, mental gender identity will be male in case of this patient. However, the external genitalia will be of female, and at puberty there will be signs of virilization. So till now we were seeing 46XY. Now we will see 46XX disorders. So most common of this is congenital adrenal hyperplasia, which is called as CAH. So the CAH, these are spectrum of different disorders because of different enzyme deficiencies, which will result in disruption of adrenal steroidogenesis. So there will be varying metabolic and biochemical consequences depending upon the rate limiting step of this enzyme. So there are three pathways. See, you can see here. So this pregnenolone is converted with the help of these three enzymes to different. It is first is the mineralocorticoid pathway, second one is the glucocorticoid pathway, and third one is the androgen pathway. So it is the same precursor pregnenolone which is converted because of different enzymes into this different its products. So in this mineralocorticoid pathway, all these enzymes are necessary. That is 11 beta hydroxylase, 21 hydroxylase, and 3 beta hydroxydehydrogenase. So this is pathway which is goes into aldosterone or mineralocorticoid. Next pathway is going into the cortisol, and third pathway will go into the androgen pathway. So this enzyme deficiencies with mineralocorticoid and glucocorticoid pathways, they will result in absence of this glucocorticoid and mineralocorticoid hormones and accumulation of the steroid precursors, which are deviated towards this androgen pathway, and there will be increased levels of DHEAs, androstenedione, and testosterone. Okay, so this is the basic thing of this CAH. There will be elevated DHEAs, androstenediones, and testosterone. In the female, the most severe form and classical form of these enzyme deficiencies, they will present as virilized external genitalia ranging from clitoromegaly to normal looking phallus. So this is the basic ambiguous genitalia. In case of female infant, it is mostly because of this congenital adrenal hyperplasia. There will be hyperpigmentation because of adrenocorticotropic hormone, because deficiency of this glucocorticoid, which will cause excessive stimulation of this ACTH and which will cause hypopigmentation. While non-classical or milder forms, they will be usually presented in case of in later life. Okay, so there will be normal female external genitalia, but at puberty there will be virilization and amenorrhea. The growth spurt might be earlier, but finally the ultimate growth potential will be reduced. So there are three types of deficiencies in this CAH. The first one and most common form is 21 hydroxylase deficiency. It is 90% of this congenital adrenal hyperplasia cases. 75% of this will have salt wasting and hypotension because there will be mineralocorticoid deficiency. Second most common is 11 beta hydroxylase deficiency. It is exactly opposite to that of 21 hydroxylase. So here there will be salt retention and hypertension because there will be accumulation of this deoxycorticosterone, which is moderately potent mineralocorticoid. And then milder form is 3 beta hydroxysteroid dehydrogenase deficiency. So this is basically, it is important, this enzyme is important for all three pathways, that is glucocorticoid, mineralocorticoid and androgen pathways. So here there will be varying deficiencies of these hormones, and there will be usually, so varied presentation will be there. Either salt wasting is there, all salt wasting will not be there depending upon the subtype. And there will be, usually there will be atypical genitalia in both. So it will manifest in both males and females. It is a milder form and it will manifest in both males and females. So in female, there will be only mild virilization of external genitalia, but so in female there will be some virilization, while in males there will be incomplete virilization. Okay, so there will be atypical genitalia in case of males. In case of male karyotype, there will not be complete virilization, will not be there. So there will be ambiguous genitalia. While in case of female, there will be mild virilization. So in both cases, it will give rise to atypical genitalia. So whenever such a patient presented to you, how you are going to investigate such patients? So when the patient is presented in infancy with atypical genitalia or bilateral impalpable gonads, okay? So here first you have to take full obstetric history to see any drug which has caused virilization. History of maternal virilization to see for any androgen secreting tumor or placental aromatase deficiency. Family history for consanguinity, atypical genitalia or any other karyotype problems or chromosomal problems. General inspection of the whole body to rule out any dysmorphic features, any anomalies. And then proper examination of external genitalia should be done to locate the palpable gonads, position, presence of urethral meatus, degree of fusion of the labioscrotal folds, presence of vaginal opening, whether it is separate from labioscrotal folds, whether it is separate from urethral opening, and size of genital tubercle. And all this score, all this external genitalia is scored by either external masculinization score or Prader scale. Okay, so there will be scoring of external genitalia should be done if it is presented as an infant with ambiguous genitalia. Then biochemical investigations, what you have to do is you have to do serum electrolytes to rule out any salt wasting, because in the infancy the most common form will be 21 hydroxylase deficiency, which will be a salt wasting. So you have to first rule out that salt wasting. You have to do serum electrolytes. You have to do serum 17 hydroxyprogesterone to see deviation of the pathway. You have to do plasma glucose, urine steroid profile to confirm the diagnosis of congenital adrenal hyperplasia. Do the ultrasound. Ultrasound of abdominal pelvis is very important because you have to first make the presence of internal genitalia. So you have to see whether the uterus is present or not, and whether if the testes are present in the undescended testes. So we have to, and ovaries. So we have to see exactly which internal genitalia are there, whether it is a male type or female type. And then if it is not corresponding to that gender, then you have to go do the karyotype. So this is regarding the infancy presentation. Now, if you find any karyotype is not, so karyotype is not female, okay, ambiguous genitalia is there, karyotype is not female, then you have to establish function of testis. So for that, the basic test is AMH levels, because this AMH levels will marker of Sertoli cell function. Along with this AMH level, you can do this SCG stimulation test. So in this SCG stimulation test, you have to give SCG and then check the levels of androgens like testosterone, androstenedione, and DHT. But this is an invasive test and it is a second line test. So basic test is AMH to see the function of testis. Here a poor testosterone response may suggest a 3-beta hydroxysteroid dehydrogenase or 17-beta hydroxysteroid deficiency. And then you have to do this short synectin test. Okay, so whenever you are not there will be a poor testosterone response, then you have to do the short synectin test. Strict gonad, sometimes it is difficult to visualize on ultrasound and MRI. So in that case, laparoscopy may be required. So laparoscopy, here you can visualize the whole genitalia, whole pelvis, and you can take a tissue sample also for biopsy in case of strict gonads, because you have to confirm whether it is an ovary or testis. Okay. Then if the patient is presented in adolescence with primary amenorrhea, so if the patient is presented in the adolescent with primary amenorrhea, then you have to take history of weight loss, exercise, stress, chronic disease, family history. So basically all causes of primary amenorrhea with female karyotype you have to rule out. Okay, you have to see for the secondary sexual characteristics. Now if the secondary sexual characteristics are there, are present, then primary amenorrhea investigation should be started at the age of 14. Now please see here, please remember this point because it may come in your this thing exam. So if the presence of secondary sexual characteristics are there, then you are going to start investigations of primary amenorrhea at the age of 14. If the secondary sexual characteristics are absent, then the investigation should be commenced at the age of 16, or if breast development is there, like in complete androgen insensitivity syndrome. So it is to be done from 5 years from the breast development. Okay, 5 years from the initial onset of breast development, or at the age of 16 years in the absence of secondary sexual characteristics. And in the presence of secondary sexual characteristic, amenorrhea investigation should be started at age of 14 years. So what are the investigations you are going to do? Again, same electrolytes you have to do, that is sodium, potassium. Then all hormone levels, female hormone levels you have to see, that is estradiol, even testosterone, androstenediol, SHBG, thyroid function test, prolactin, HSH, ultrasound of abdomen pelvis. And if ultrasound doesn't confirm the presence of uterus, then you have to do the karyotype. Now adolescent girl which is presenting with amenorrhea and with virilization. Okay, this was a recall question also. So adolescent girl, whenever she presents with virilization and primary amenorrhea, it is usually a classic presentation of 17 beta hydroxysteroid dehydrogenase deficiency or 5 alpha reductase deficiency. So these are the basically male karyotype, and there will be female phenotype will be there. So here psychological impact is very, because from the birth they are raised as females, and at puberty because of this peripheral conversion they are having this virilization features. Okay, so here you have to do the examination and history taking very sensitively. So here the biochemical investigations which are required is testosterone, androstenedione, SHBG, DHEA and 17 hydroxyprogesterone, FSH, LH, urinary steroid profile, and ultrasound of abdomen and pelvis. Here, if the uterus structure, that is female internal genitalia, is present, then it will be congenital adrenal hyperplasia. And in case of androgen secreting tumors, so uterus will be present if the uterus is present with virilization. Remember well, female karyotype, presence of uterus, and virilization with primary amenorrhea, then it is congenital adrenal hyperplasia or androgen secreting tumor. While in case of absent uterus, then it is usually a 17 beta hydroxysteroid dehydrogenase deficiency or complete androgen insensitivity syndrome. So karyotype is required if uterus is not there. Okay, if the uterus is not found on the this thing ultrasound, then karyotype should be done in these cases. Now, management of such cases. So first and foremost is psychological support is required, and that is the paramount importance because it is a gender identity issue. The patient may be raised as a female and she may present it with virilization and primary amenorrhea. Sometimes it will be a totally ambiguous genitalia. Sometimes the infant is present, the parents will be stressed. So it is a psychological support, it is required. Now regarding gender assignment, which gender to be decided. Now it is, you have to remember that sex is a biological term which describes karyotype, gonads and reproductive organ. While gender, it is a social term which refers to the psychological experience of that individual, whether that individual perceive himself or herself as male or female. Okay, so gender, it is a psychological issue Well, sex, it is depend upon the karyotype and phenotype. Okay, so basically you should not be in hurry to gender assignment. Even if in infancy you find any problem, then you should not be in hurry to assign the gender. Allow time for investigations and multidisciplinary discussion to happen. Some families may elect to raise their child as gender neutral until they are old enough to decide for themselves. So now in Western countries, it is common that if they, because gender identity issues has becoming more common in adolescence. So for that, if they find any ambiguous genitalia, it has become common that they will not assign the gender in the infancy, and they will give time so that the that person or that individual, once they reach at the proper age, then they will decide themselves which gender they want to belong. Okay, and in that case, gonadotropin GnRH analogs can be given at puberty to temporarily block virilization. Okay, so to allow that child to decide their gender by themselves. Then in there are also comorbidities will be there with this issues. So like cardiovascular, metabolic, autoimmune or neuropsychiatric comorbidities will be there. Also there will be reduced bone mineral density. So this reduced bone mineral density, it is present in 70% of women with congenital adrenal hyperplasia because of this exogenous corticosteroids. Again, short stature is a feature of Turner syndrome. So in that case, you have to give this proper appropriate hormone replacement therapy and this thing for and growth hormones for the growth spurt to improve height and to reduce this bone loss. So this hormone replacement therapy, these are the exogenous hormones. These are carefully tailored to mimic physiology, and it can be given to the patients with insufficient gonadal function, okay, which may not reach the puberty. So which hormones? So this hormone replacement is given to develop secondary sexual characteristic, growth of uterus, to promote adolescent growth spurt, normalize bone mass and psychological maturation. So basically it should be started at the age of 11 to 12 years with low dose of estrogen. It should be started and slowly incremental doses should be given. And finally, a cyclical progesterone should be given to induce a withdrawal bleed. Okay, to reduce the risk of endometrial hyperplasia. So it is usually tailored like that. You have to give the estrogen in the incremental doses, and once the patient develops the withdrawal bleed, then you have to maintain it by consecutive estrogen and progesterone. But there is no proper agreement on which estrogen regimen to be followed. Like you can use oral ethinyl estradiol, 17-beta estradiol, or transdermal estradiol. But estrogen should not be given in high dose because it should not be increased too fast because it will impair final height attainment or breast development. This HRT should be continued till the age of menopause. Now regarding fertility, now it again depends upon the gender, what is the karyotype is there, okay, and again it is the gender identity will also depend upon the fertility, okay, because it is dictated in part by fertility potential of that chosen gender. So this fertility is again affected by hormone levels, presence of uterus and ability of sexual functioning, both anatomical and psychosexually. So previous genital surgery also affect both sexual function and delivery option. If infancy genital surgery has been carried out, again it will affect this fertility potential. So basically for Turner syndrome, there will be adequate ovarian function. So they will attain the menarche, but then they will go into the POF. So in that case, early oocyte cryopreservation or embryo freezing can be done. Okay, if they have this menses and ovarian tissue is there, then you can do this ovarian cryopreservation or embryo freezing. For congenital adrenal hyperplasia, spontaneous conception is possible, but the pregnancy course is complicated because of all this salt wasting and all this. They require replacements, and it should be managed in specialist center. XY females with uterus, they they might be able to carry the pregnancy by egg donation. So now again in 2015, they have reported uterine transplant, okay, live birth after the uterine transplant. So this is again a new avenue. And another thing is a ovarian tissue freezing in childhood, okay. So germ cell harvesting after future autologous transplantation. So preservation of ovarian tissue and then again retransplantation. So these are the options for the fertility. Then role of gonadectomy here. So gonadectomy when the karyotype is XY and phenotype is female. So usually here the testes are undescended and the fate of the testes remain controversial. So previously, traditionally, there was a policy to remove the gonads at the time of diagnosis. So early gonadectomy was done previously. Okay, because the advocates of this early gonadectomy, what they said that because assigning gender is distressing afterwards, because presence of gonad, they may have this gender identity changes, and then also a risk of this retention of this undescended testes, it will carry virilization, or there may be chances of malignancy. So this malignancy chances in case of partial androgen insensitivity syndrome is 15%, 30 to 50% in gonadal dysgenesis, and 28% in 17 beta hydroxysteroid dehydrogenase deficiency. While in complete androgen insensitivity syndrome, the malignancy chances of germ cell tumor is only 0.8%. So wherever there are malignancy risk is low, early gonadectomy is not required, because if you delay this gonadectomy, there will be spontaneous onset of puberty and the bone mass will be preserved. Okay, so in case of low malignant potential, removal of gonad can be deferred till the adolescent. Okay, so that the child or the children, when they reach adolescent, they can take their decision of gonadectomy. Okay, so it is not a parent decision for gonadectomy, because sometimes they may challenge afterwards. And there have been reports that if you do the gonadectomy, there will be loss of libido also. So when the chances of malignancy is less, it is better to defer the gonadectomy till the spontaneous puberty is reached. Then also, some people, some women with this congenital androgen insensitivity syndrome, complete androgen insensitivity syndrome, they are avoiding gonadectomy, because as you see here, the malignancy chances are very low. So they are avoiding gonadectomy totally. Okay, so it is their decision, but only thing they should be counseled regarding the imaging modalities and tumor markers, so that you have to do that, but they are not sensitive enough for monitoring and screening purposes. And but the high risk for malignancy, early gonadectomy should be done. So like for gonadal dysgenesis, 46XY gonadal dysgenesis, you have to do early gonadectomy. So again, this slide is important. When to do the gonadectomy, it is dependent on that. Now another is gender surgery, gender related surgery. So feminizing genitoplasty. So this genital surgery in DSD, it includes vaginoplasty and genitoplasty. So it will be clitoroplasty with or without labioplasty. It is usually done to facilitate the penetrative intercourse and favorable cosmetic appearance. It separates the vagina from the urethral opening to reduce urinary complication and to achieve gender typical urination. But the time of surgery is controversial, because if you do it in infancy, okay, when performed as a single procedure, the resected tissue, it can be utilized like phallic skin for use can be used for clitoroplasty or reconstruction of vagina. But here, if you do it in early childhood, vaginal stenosis is a common complication, and again, post-operative long-term vaginal dilatation is required. So the guidelines for this genitoplasty are right now, if the child is undergoing genitoplasty for virilized, so virilized genitalia, if virilized genitalia is there, then vaginoplasty and separation of a common urogenital sinus should be performed at the same time in the childhood. For those with hypoplastic vagina only, first line treatment is non-surgical vaginal dilatation. So remember well, if the virilized genitalia are there, then the genitoplasty should be done in childhood and separation of urethral and vaginal opening should be done. But only hypoplastic vagina, like you see in complete androgen insensitivity syndrome, in that case, first line treatment is non-surgical vaginal dilatation, and this should not be done prior to adolescence because it requires this patient's commitment and motivation. Success rates, these are quoted as being as high as 80%. Like success rate is measured by to have normal vaginal caliber and ability to have penetrative intercourse. So the success rate are 80% with use of vaginal dilators. And for those who find this vaginal dilatation unsuccessful, unacceptable, or intolerable, surgical vaginoplasty is considered as second line treatment, and it is usually done after the adolescent, not before that. Okay, so this is regarding the TOG of disorders of sex development. There are no questions on this TOG till now they have given, so I have not included them. So, but usually the questions are asked on this complete and partial androgen insensitivity syndrome and the investigations regarding this virilizing amenorrhea. Okay, so you should know which investigations to be done. So this was the today's talk. Tomorrow we will meet with another talk. Any doubts or any questions? Okay then. Bye for today.
Thank you, ma'am.